Welcome to our masterclass on corneal topography. Now, if you're a practicing optometrist or an advanced student, this is for you. We're going to give you a structured, ground-up understanding of one of the most essential tools in modern eye care. So let's get started.
Okay, let's dive right in. Here's our game plan. We'll start with the fundamentals, then we'll explore the different kinds of topographers out there. After that, we'll learn how to actually interpret their maps, analyze the data, see what else these modern devices can do, and we'll finish up with some key principles for your day-to-day practice.
All right, let's start at the very beginning. What is corneal topography, exactly? And why has it become such an indispensable tool in our field? Let's build that foundation.
You know, the name itself gives us a fantastic starting point. Topography comes from the Greek words topo, which means place or terrain, and graphia for description. So we are literally describing the surface of a terrain. In our clinic, that terrain is the patient's cornea.
And wow, what a critical piece of terrain it is. The cornea is an absolute powerhouse, responsible for roughly 2/3 of the eye's total refractive power. That's about 43 diopters. So you can see why understanding its exact shape is absolutely vital for understanding a patient's vision.
This importance leads us directly to its main clinical uses. Think of a topographer not as a single-use tool, but as a versatile platform. We use it to detect pathologies like keratoconus, to precisely fit specialty contact lenses like ortho-K, to evaluate visual quality issues, and of course, to plan and track the results of refractive surgery.
So we know why it's so critical to measure the cornea. Now let's look at how we do it. In this section, we'll explore the different technologies that power these incredible instruments. There are really three fundamental systems out there. The most common one, the one you'll find in most optometry clinics, is based on reflection, using Placido's discs. Then you have newer systems based on projection. And finally, elevation-based systems, which are more typical in ophthalmology settings.
So how does that common reflection system work? Well, it's elegantly simple. The topographer projects a series of concentric rings of light, the Placido discs, onto the cornea. The cornea acts just like a convex mirror, reflecting those rings back. The instrument then captures and analyzes that reflection to map out the surface.
The key to interpreting that reflection is simple. It's all about the spacing of the rings. Where they're close together, the cornea is steeper and more powerful. Where they're spread apart, the cornea is flatter and less powerful. It's that straightforward.
Now, what's really interesting here is the trade-off within reflection topographers. We have two main designs, narrow cone and wide cone. A narrow cone gets closer to the eye, giving you a wider measurement area and fewer shadows from the nose or lashes. But the capture is trickier. The wide cone is the opposite. It's farther away, making the capture simple and repeatable, but it covers less area and is more prone to artifacts. The pros of one are basically the cons of the other.
Okay, we have the instrument. We've taken a measurement. Now comes the most important part, interpretation. Let's learn to read the language of the cornea through its topographic maps.
The very first step is understanding the universal color code. Think of it like a weather map. Cool colors like blue indicate flatter areas, lower powers, or depressed zones. Greens represent your average, middle-of-the-road values. And the warm colors, your reds and oranges, they signify steeper curvatures, higher powers, or elevated areas.
Before you even begin to analyze a map, you have to check the scale. With an absolute scale, the color bar has fixed, wide limits. This gives you less detail, but is essential for comparing maps over time, say for tracking a pathology or an ortho-K treatment. A relative scale adjusts its limits to the specific cornea being measured, showing much more detail, but making it completely useless for comparing one map to another.
And this brilliantly breaks down the two main curvature maps, which really answer different clinical questions. The axial map gives you a big picture overview and is best for evaluating the patient's vision and for general contact lens fitting. The tangential map is more precise, especially in the periphery. Its purpose is to evaluate the true shape of the cornea, making it critical for detecting subtle changes, tracking ectasias, and managing ortho-K. Beyond curvature, there's another crucial map. As specialist Sergio Bogato points out, the elevation map is often the go-to favorite for fitting contact lenses. Let's look at why.
The elevation map doesn't show curvature, it shows height. It compares the patient's cornea to a perfect best-fit sphere. Red areas show where the cornea rises above this sphere, a prolate shape, classic in keratoconus. Blue areas show where it dips below, an oblate shape, typical after refractive surgery or an ortho-K. This gives us a true 3D sense of the corneal landscape.
Now,
Let's shift from the visual maps to the hard numbers. We're going to look at the specific indices and aberrations that quantify the cornea's shape and its direct impact on a patient's visual quality. Every topography provides a set of key numerical indices. SimK is your simulated keratometry. Eccentricity, or the E value, tells you how quickly the cornea flattens from the center to the periphery. Then we have indices that quantify the smoothness of the surface, like the Surface Regularity Index, SRI, and the Surface Asymmetry Index, SAI. For these, lower is better. Finally, you have screening indices like the Keratoconus Prediction Index, KPI, which are software-specific tools. The topographer can also give us insight into optical aberrations. Low-order ones are the basics: myopia, hyperopia, and astigmatism, which affect the quantity of vision and are easily corrected with glasses. High-order aberrations like coma and spherical aberration are more complex. They affect the quality of vision, causing issues like halos and glare, and often require advanced corrections like gas-permeable lenses. You know, modern topographers aren't just single-purpose devices anymore. Let's quickly explore how these instruments have evolved into multi-diagnostic platforms with a range of powerful clinical applications. Today, many topographers can also accurately measure the horizontal visible iris diameter, perform pupillometry in various lighting conditions, simulate contact lens fits, analyze the tear film for dry eye, and even provide corneal thickness measurements, or pachymetry. They've really become the Swiss Army knives of the optometry clinic.
But this evolution does spark a debate among experts. One view from Sergio Bagato is that the topographer is becoming a more complete all-in-one tool. The opposing view from Epi argues that a device trying to do everything is often not excellent at any single function. It's that classic specialist versus generalist debate.
To finish up, let's focus on the most important part: getting good data. We're going to run through some critical clinical principles to make sure you get reliable, accurate measurements every single time. Here's a key takeaway. A high-quality topography starts before you ever hit the capture button. First, evaluate the tear film. It means to be stable and homogeneous. Don't hesitate to instill an artificial tear if you need to. Always ask the patient to blink right before the measurement. And most importantly, if the ocular surface isn't healthy, if you see keratitis or staining, treat that first. Garbage in, garbage out. A pristine surface is non-negotiable for accurate data.
And that leaves us with one final question for you to reflect on in your own practice. Are you treating the data from your topographer as just a simple set of numbers for a formula? Or are you seeing it for what it really is, the essential first step toward a deeply personalized treatment plan for every single one of your patients?